I want to welcome everybody to this Ask a Brain Doctor session with tech-savvy Dr. Richard Isaacson, the preventive neurologist of the Institute for Neurodegenerative Diseases, founder and science lead of Retain. I'm Paula Spencer-Scott. I run all the content on Retain, and I'm the author of a book called Surviving Alzheimer's, through which I first met Dr. Isaacson many years ago. And yeah, we're ready for a new session and have so many questions that have come in, like many, many questions. Some are very general, some are very specific, and we'll try to get to as many of them as we can.
Great. Well, thanks everyone for joining. I just want to say I'm pretty excited that we have a whole Retain specific. This is a special audience where only Retain Your Brain users get to join. And for those of you who are unaware, when I was started the first Alzheimer's prevention clinic back in the United States back in 2013, man, a dozen years ago, and Paula Spencer-Scott. I can say this: you were one of our patients. You were one of
Yeah.
our first patients. Your data was in our 2019 research study that we published that we showed that, hey, guess what? Reducing risk of Alzheimer's actually works. We can make brain function work better after 18 months of, doing the thing. We had a 4.5 year waiting list. 4.5 year waiting list at the Alzheimer's Prevention Clinic when I left, and like that's not okay. So what we did is we wrote an NIH grant, a grant that we got funded, thankfully, from the government back in I think this was about 2020, COVID days. Everything kind of blends together, and we got funded to create basically a virtual neurologist in your pocket. What we do in the Alzheimer's Prevention Clinic, our lead developer kind of came in, our guy that kind of wrote the whole prototype, sat next to me in the Alzheimer's Prevention Clinic and said, Dr. Isaacson, this is what you're doing. And now look, this is what we're going to do with software. And this was before the days of AI. And, we were kind of early adopters. And basically anyone today can use our software and try to like learn more. This is the early versions of the software. We have lots of new features coming, lots of stuff, not just going to learn about risk, get a targeted plan, but we're going to be launching really cool, exciting things in 2026. And one of those things is this Q&A, and hopefully we can do more of these. And if you have feedback about this Q&A, if you have feedback about our software, if you have suggestions about what we could do better to help you, we have over 10,000 people that joined in just a couple of months when we launched this initial beta. 10,000 people. I can't see 10,000 people in my life as a doctor. So it's just like really super cool to be here with you today. I'm excited. Thank you for joining. And I'll stop blabbing along. It's 3 minutes past the hour. So Paula Spencer-Scott, let's go.
Yeah, let's dive into the questions.
Great.
The first two are concern recent items that have been in the news. People were asking about, and so I thought I'd just start with those.
Great. Love it.
Can you comment on the recent research regarding the number of steps of walking daily and brain health as a protective effect? And I'm guessing this is a November 2025, just a couple weeks ago, study in Nature. You want to talk about?
Yes. So yeah, and actually, CNN did a piece on this, both online. Sandy Lamott is a great brain health reporter. I believe she did the paper, and then Ivan Rodriguez actually did a hit for some of the local TV. So if you want to Google that, you can learn a bit about it. But long story short, to me, more steps is better. Sure, being active is better. Being sedentary, meaning like you just sit around and you don't get physical exercise. Physical activity is better than being sedentary, meaning just sitting around and not being active. Physical exercise is different though, and I truly believe that physical exercise is better than being physically active, different, just being active, like walking around and doing things. And, I don't think that there's a magic number of steps, 5,000, 7,000, 10,000, that can, prevent or reduce our risk of Alzheimer's. I think everyone needs an individualized exercise and activity plan for them. So what I mean by that is you can do all the walking you want if you're walking slowly. And if you just ate a really big fatty meal, you're not going to lose weight. You're not going to really gain muscle. You're just going to walk. And walking is good because it, speeds up digestion and it's better, just to, burn some calories. But for example, if you have a belly fat that I had a belly too, and then I learned because I was doing Peloton and I was working hard and I was sweating and my heart was getting stronger, my resting pulse was getting lower, but I wasn't losing belly fat. And that's what I learned, during COVID times. It took a while for me to learn this, that I wasn't in fat burning mode. Steady state, low intensity cardio, walking fast, getting your heart rate up to about 60%, of its maximum. And the way that you can kind of figure this out without fancy tools is, can you have a conversation with someone either on the phone or next to you? You can still have a conversation, but that person that you're talking to knows that you're kind of exercising a little bit. So you're a little bit out of breath, but you're doing okay. If you can walk fast, and what I needed to do, because I run a lot, I run long distance, I do half marathons, I put on a weighted vest. And when I walk fast in a weighted vest, I can get my pulse to a level that after 45 to 60 minutes, I am burning body fat. And personally, and if your doctor says it's okay, that's cool. Personally, if you do this while fasted in the morning, then you don't have the carbs, and the stuff in the blood, so you can even break down fat even quicker. So to me, walking is great. Walking fast with a weighted vest, and as an old colleague of mine, Dr. Sanjay Gupta, who did a CNN documentary on the work that we did and talked about retain your brain software, he said take a brisk walk with a friend and talk about your problems, and that's a good saying. But I addend that to take a brisk walk with a weighted vest. Talk about your problems. Make sure that the other person and you are talking, but a little out of breath, and maybe fast before you take the walk. So I think doing that is good. Building muscle mass is key. I'll be honest. When I lived in New York City, I was on this step kick. Over a decade ago, I was at 9,700 steps, and I went outside and I walked around the block twice, and I came back up and I said, "Yeah, I got my 10,000 steps." I think that's a little silly. I think you need to be more intentional. You need to do muscle strengthening, stretching, yoga, other stuff, movement exercises. So long answer, but I don't think it's just about the steps.
Great. Great. Thank you.
Mhm.
This next one you have discussed in these Q&A sessions before, but now there's a news element to it, and it was the probably number one topic people asked about in various ways. The questions boil down to this.
Okay.
The black box warning was lifted by the FDA on the
Yes.
risks of menopausal hormone therapy for women over 60. And so the questions all pertain to what is the role of HRT in Alzheimer's prevention, for who and what timing, especially women who are beyond menopause are seeing this and are now curious, who are, past 60.
Yeah, this is great. So first of all, I want to say that one of the greatest injustices in medicine, and this may sound like a big statement, but I believe it. I said this at a thing. I got to hang out with Dan Butner of the Blue Zones a couple nights ago. Super fun, and he asked me the same question. It's the first time I've responded to this since this happened. One of the greatest, you know, uh, sad things that happened in America for women was 20 plus years ago. There was a black box warning put on hormone replacement therapy. And that was the black box warning, just so everyone's aware. The FDA, when they review data and they say that a drug could cause harm, but some people could benefit, but you really want to be careful because it could cause harm in certain people. They're going to put a black box and say this is bad and could cause, cancer or this or that. And what happened was is that in the women's health study, and I'm not going to go too deep into this, but the women's health study had a finding and had some findings when they used hormone replacement therapy where certain women had bad health outcomes, whether it's cancer, a blood clot, whatever it is, right? The challenge here is that study was done so long ago. It was done with a type of hormone, like some of the hormones were like purified from horse urine, like mares, like female horses' urine. They took the hormones out and they gave that to women, and there were side effects. Imagine that, right? Well, in 2025, we have bioidentical hormones, meaning like hormones that are the same that the woman actually produces, the estrogen, right, the progesterone. So the difference between the hormones we have today versus the hormones that we had, decades ago, it was all conflated and discombobulated and put it all together, and there was generalized badness, black box warning. And because of that, too many women have suffered. They've suffered with night sweats. They've suffered with brain fog. They've suffered with all sorts of things. And doctors just shrugged it off because they said, "Oh, okay, well, yeah, okay. I don't know what you can do about it. No, you can go on these hormones, but it could harm you, so let's just skip." And the women suffered, and that's bad. The other part about hormone replacement therapy, women during the perimenopause transition, the estrogen starts to drop. And when the estrogen starts to drop suddenly, that's when that amyloid, the sticky protein that builds up in the brain of a woman with Alzheimer's, builds up. And 2 out of every 3 brains affected by Alzheimer's are women's brains. And we used to say we don't know why, and I believe that we should know why because we've done more research now. And in certain women with one or more copies of the ApoE4 variant, this is a genetic combination, 25% of people out there have one or more copies of this gene called ApoE4. And in those women, when that estrogen drops, we showed this in our Cornell studies and the Women's Brain Imaging Initiative. we showed that the estrogen drops, amyloid goes up. So guess what? In the women that were on hormone replacement therapy, guess what happened? Not only did the amyloid not accumulate like that, but the brain volumes were larger.
Mm.
The brains didn't shrink. So to me, I believe that in the right woman at the right dose for the right duration of time, hormone replacement therapy could be our most valuable, or even more conservatively, one of our most valuable top five. Exercise on a regular basis, Mediterranean style diet, da 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 da. But hormone replacement therapy during the perimenopause transition for specific women, especially at higher risk with the genes, super powerful. And yesterday, actually hot off the press, I can talk about it. It's past embargo. Our group, our amazing PhD, Dr. Christopher Janney, our principal scientist, and John Westine over at IND, the Institute for Neurodegenerative Diseases, ind.org, we presented at the Society for Neuroscience conference in San Diego that when people who are at risk for Alzheimer's in our cohort followed a plan to reduce risk, including hormone replacement therapy, which was one of the therapies that showed significant improvements on brain biomarkers before and after. Pretty cool stuff. The people that had the greatest adherence to lifestyle changes, taking their hormones, doing whatever else, were able to have even better outcomes by improving their brain proteins that put them at risk for Alzheimer's, amyloid, and also a protein called tau that we can check in the blood. So what I want to say is, it's a long answer, but it's really important. In the past, we had imprecise information, we had imprecise molecules. Now we have real world evidence in humans and women and men too, that when you do these things and you give HRT specifically to women, you can have improvements in brain biomarkers, and also cognition also seems to do well too. So big, big, big day for women in the United States.
Great, thank you.
Mhm.
Related to that about hormones, a woman says, I'm an ApoE44 female who's wondering about starting testosterone for brain support.
Mm.
What about testosterone, which is,
Oof, that's a hard question. That's a good question. So here's what I would say. Um, I do not fully know the answer to this question, not because I haven't studied or read about it, because I don't think science knows. I can also tell you that this is something that has an answer that is, I would say, morphed a little bit in my head over the last 5 to 7 years. When I first heard of a woman going on testosterone, I was like kind of confused. I'm like, what is it? What? Wait, I don't get it. Women, as they get older, the testosterone just goes to really low, and that's just normal, right? And also, let me answer this question for men too, because I think this is a really common question for men. Should men go on testosterone? And if so, will it help or hurt the brain? And my kind of, I'll say naive, but I'll also say like not my fault because I was never taught any of this in medical school or residency, and most doctors don't get this education. I would say that testosterone wasn't something that was a good idea, period. I don't know, men maybe prostate cancer, and women, I don't even know what. My opinion on this has shifted. And I've only seen maybe a handful of women, honestly, half a dozen, if that, that have started on very low dose topical testosterone. And those are for women that had low testosterone, that also had trouble, a clinical thing. So it's not just a lab. You don't just want to treat a lab test. You want to treat the patient, right? That woman or those women had trouble gaining muscle. They were eating protein, they were eating carbs because you need protein and carbs to build muscle. They were doing everything right. They were, strength training and doing all the things, and they weren't able to put on muscle. And the tiniest of tiny little bit of testosterone, topically, minimally, got to be careful with that stuff, led to better muscle growth. And in a few women in our cohort, actually, the lab started to look better. And I'd never seen anything like that before. So I am not opposed to testosterone used in the right woman at the right dose for the right duration of time, in only if someone, I think, is symptomatic, not just treating a lab, and in the hands of a clinician, of a healthcare provider that really knows what they're doing. I think that's really important. And men, it's kind of similar. Again, this is weird because I remember I had a conversation with this probably 2021, 2020, and I was like, no, 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 careful, careful, careful with testosterone. Men, prostate cancer, bad, revving the engine. Well, there are studies that show that testosterone use in men may preserve cognitive health. Now, I don't know if that prevents Alzheimer's, but I think it may prevent cognitive health, or sorry, cognitive decline anyway. But again, it's about the doctor or the a clinician. Like I've seen crazy testosterone levels, crazy high. Like really, is it really super therapeutic? Like are they trying to be Superman? Like if a guy is having trouble gaining muscle or having trouble with libido, or like yes, if someone is low testosterone and they have symptoms, don't just treat a lab. I'll say that 3 times. Then maybe there's a rule for it. But with men during the andropause, women go through menopause in their late 40s, early 50s, mid 50s, probably usually the latest. Men also go through an analogous phase about a decade later, so late 50s, early 60s. And you have the testosterone come down. But once you go on testosterone for a man, after you're on it for 6 months, you're on it forever. Can't come
Mm,
off. So there's some challenges here. I'm a less is more kind of guy, but testosterone may have a role in certain people with some caution.
okay. Um, I want to ask one more hormone question, and then we have a lot of other things to get to. But if you could craft a quick response, because multiple people have asked in our live Q&A about this, about hormone therapy for women who are past 60, past
Mm.
65, past 75, people have asked, should they start now? We didn't take it before. Should we start now? Just a quick
Mhm.
guidance for that situation.
Quick guidance. Yeah, thanks, Paula. Yeah, Paula. Yeah, quick guidance. Yeah, that's an easy one. Yeah, I'm getting. What happened to the softballs? The first few Q and A's.
I'll
It
give
was,
you a good one next.
it was like our blueberries good for the brain, and now you're hammering me here. I'm getting hammered all day. I swear. Okay. So in my clinical experience, managing, I would say a few dozen, but not 100, and not more than that, women aged, let's say, mid to late 50s and early 60s, and even mid 60s. Um, I have, on occasion, in collaboration with the treating primary care physician and GYN, I don't prescribe the hormones myself, and actually also preventive health doctor has helped me too. And we collaboratively felt that using hormone replacement therapy, even after menopause, may be helpful for that woman. And we've actually tried it. We've tried it in women in their late 50s. We've tried it at age 60, and the oldest we've tried it is a woman at the age of 67. And that is something that you just don't hear. You just don't hear that kind of stuff. And we do this within the construct also, not just of clinical care, but of research. So we do a research and we do the blood biomarkers before, we do the blood biomarkers after. These were driven by women being at higher risk of Alzheimer's and having the proteins that were elevated. These are women that were having some cognitive, symptoms sometimes, otherwise that were normal. And these are women that had other kind of things, symptoms that could have gotten like for example, bone density, low bone density, for example, osteoporosis, other sorts of things too. So we've used it, and in a very small number of people that we've objectively measured brain hormones, brain not hormones, brain proteins, amyloid, tau, other markers. We've shown in a very small cohort, not fully published, only presented in abstracts at meetings, and we presented some of these data at the Alzheimer's Association International Conference this past summer, that even starting hormone replacement at 60 plus in a small number of women was safe, and actually had positive effects on brain hormones. That being said, one of the women, after being on hormones till from 60 to 62, just a few months ago, started having vaginal bleeding. And something, happened. She had to have a procedure, and now she had to have a change. So, it, life is about risk versus benefits. And I do think that the jury is still out, and we have to be very cautious, like extremely cautious about starting hormones late. But in a select few women with good medical, comprehensive, multidisciplinary care, we have actually tried this.
Okay, here's your softball.
Okay, thanks.
If there was one vitamin to absolutely take for brain health, what would you recommend?
Like that was a softball. There's
Well,
no
it's
there.
just a one answer.
Well, yeah, but like I can't. You're killing me
You
here.
can
I
give your
swear.
vitamin
I woke up to what? Is there a
POV.
full moon today? Okay. So everyone everyone, different people may have a different answer to this question. That's I guess the challenge. And what I mean by that is, if there's someone out there that's low vitamin D, so 60% of people that live in Miami, I'm about an hour away from Miami. 60% of people that live in Miami have low vitamin D. For people that have 2 copies of the ApoE4 variant that have very low vitamin D, maybe vitamin D is the right answer to this question. I think maybe the softball that you were going to say is B complex vitamins. That's what I think you thought maybe what my answer would be. And interestingly, I did a program, a lecture last night to doctors, and there were several hundred doctors on. There's just like there's hundreds of people on today, which is super cool. And one of the doctors that was on said B vitamins don't do anything. And I didn't, I don't want to cause controversy in front of like a whole thing. And it was like this whole program. I don't agree with that. So B complex vitamins, I'm going to sound like a broken record, in the right person at the right dose and for the right duration of time, I do believe can have a beneficial effect on brain health. However, not in everybody. So the VitaCog study, VITACOG, published in 2012, David Smith and Helga Refsum and colleagues, VitaCog studies showed that if a person has a blood marker of elevated or high homocysteine, homocysteine is an amino acid in the blood, those people that took B complex vitamins were able to slow brain shrinkage over time and maintain memory better than the people that didn't. However, in those people, the B vitamins only worked, or they work better, if you had adequate levels of omega-3 fatty acids in the blood too. And those are things from fatty fish like lake trout, mackerel, herring, albacore, tuna, wild salmon, sardines. And sometimes people need to take supplements. Always try to get the nutrients from the food, but you have to take supplements sometimes. So to me, this answer is complicated. I know everyone wants to just like get a quick answer. I'm going to go to the store and I'm going to like take a pill and then like, see you later. I'll be fine. But it doesn't work that way. For me, I don't know if I've ever shared this publicly, but this is my Retain Your Brain family. So this is different, this isn't going on YouTube for everyone to see. This is for Retain Your Brain users only. So this is cool. So don't repeat this. Gosh. I have elevated homocysteine. So one of my risk factors for Alzheimer's disease is high homocysteine. My dad had it and I have it. I was just 13. I stopped taking my B vitamins. I ran out. Okay, it happens. I'm guilty as charged. And I stopped taking my B vitamins. My homocysteine went up to 13. And I started taking my B vitamins again. And the take home point here is everyone needs to personalize the vitamins and supplements for you. And I also checked my omega-3 fatty acid levels. They were okay, thankfully. So I didn't need to take, change my supplements or increase omega-3 fatty acids. So I think that's what I would say. Yeah, I guess that's what I would say. That was an easy question. I don't think that was that easy.
Okay, here's a maybe yes or no.
Oh,
Do you recommend the Shingrix vaccine, the vaccine for shingles? There was,
great.
recently a article about that. I think in,
That's a great question. So I am very bullish or very positive or very pro the Shingrix vaccine. Why? Okay, this isn't a vaccine question with political or this or that. Not going to talk about that. This is about a vaccine that helps prevent shingles, and shingles is a virus. First of all, shingles hurts. Shingles is a reactivation of a virus. It's a painful, blistering rash that's caused by varicella zoster virus. You may remember varicella zoster. That's called chicken pox, like when we were little. And I used to get that, and all the kids got it. And sometimes we had chicken pox parties so we could just all get it over with together. And it's a reactivation that causes pain, tingling, and itching in blisters. Okay, it's like a herpes type blister that is around like the side, and it's like my mom got that and it was bad. Like she was in pain. Like shingles hurts. So why do I think the shingles virus is helpful? Number one, it prevent an outbreak of a painful thing. That's helpful. It lasts for 7 to 10 days, but the rash can last for weeks. This virus lies dormant in the system, and if you can take an antiviral drug when you get it, it may help a little bit. But the best way ounce of prevention is worth a pound of cure, right? The key here is if you take the vaccine, you can stop the reactivation. Why did I go into that much detail? It's because that reactivation causes inflammation. And viruses, you heard it here first, can spike brain proteins related to Alzheimer's disease. When we do blood tests for Alzheimer's in our program, we see all the time. Someone could have COVID, for example, even asymptomatic, and their brain proteins are higher. Their tau is elevated. I had a guy, twins, one with a herpes simplex virus, a cold sore. The other guy didn't have it. They were sitting like next to each other, and we did their blood. And one guy's these guys young guys in their 40s, tau protein out to wazoo. It looked like the person in Alzheimer's, but then a few weeks later, it came back down. So you heard it here first. Viruses can spike these proteins. And as we get older, the last thing we need is to spike these brain proteins because sometimes they spike and they don't come down. So I believe that a Shingrix vaccine, based on the data, this is data-driven research, people with the Shingrix vaccine are less likely to develop dementia and
Well,
Alzheimer's.
that article is in Nature Medicine last month, and it said that the vaccine was associated with a a decreased dementia risk. And what
Mhm.
astounded me about it was based on the records of 100 million people. Like that was a lot of data for that.
Wow.
Yeah, that was seemed pretty
Wow.
large. So,
Wow. Okay,
um,
good to
okay, do you need to adhere to the MIND diet 100% for it to be effective?
know. Wow. So, it's kind of like compounding interest, like when you put your money in the bank and then you get, now we're down to 3 point something percent interest and you put $1,000 in, you make $30 a year, whatever it is, and it compounds. I think that the greater adherence you have, the better you'll do, the better the person will do. Our data suggests that. We showed both in our paper our poster we presented at the Society for Neuroscience literally yesterday morning, and the paper we published in 2019, that greater adherence to lifestyle changes and people that followed greater than 60% of the recommendations did better, in terms of their optimization of cognitive function. So I think more is better. But I also think that we have to live and we have to enjoy ourselves. If you eat lots of green leafy vegetables, that's really good. But if you're eating I don't know, processed foods and fried foods and fatty foods and fast foods, in addition to green leafy vegetables, and well, then that kind of negates a lot of the positive of the green part of the mind diet. And the mind diet is like a modified Mediterranean style diet. And, I think it also depends on the person. Like if a person's exercising regularly, whole grains I think are okay, are healthy. But I think a lot of people eat a lot of carbs and whole grains, and not all carbs are created equal. Added sugars, not so good. High fructose corn syrup, not so good. The stuff in soda. But a piece of whole wheat bread, like that's good. That's okay. But like 8 slices of whole wheat bread, that's a lot. So I think when it comes to the mind diet, it's better adherence is better. Berries, those are really good antioxidants. If you refuse to eat berries and drink lots of alcohol, that will negate a lot of the mind diet, even if you eat green leafy vegetables every day. So I wish I could get a little more granular, but more is better.
Regarding leafy green vegetables,
Mhm,
which are part of the MIND diet,
mhm.
someone says I take Coumadin daily. I can't eat a lot of leafy green vegetables. What can I do?
Ooh, um, okay. So I'll just start by saying I'm not your doctor, and I am going to try to give some general advice and information. Coumadin is a drug that has been used for decades. There is a different drug and a newer drug, which is a little bit of a different of an anticoagulant drug. Anticoagulant means a drug that stops clotting in a way that could help someone not get a blood clot. Not getting a blood clot is good. And there are newer drugs now that are different than Coumadin that may be better if a doctor says okay, or PA or NP, any healthcare provider decides that there is a different drug that could be better tolerated with less, blood draws to check your INR level, your Coumadin level. Um, so what I would say is, yes, you have to be careful there. If you cannot have green leafy vegetables, there are other things that a person can do, in terms of, antioxidants. So berries, for example, blueberries and strawberries, a half a cup 2 to 3 times a week. And the Nurses Health Study showed a delay of cognitive decline by 2 years. Dark cocoa powder, also lots of antioxidants, purified dark cocoa powder, added to coffee, or not a Hershey's bar. I love Hershey's bars. I love Hershey's Kisses. You heard it here first, but that's not chocolate. That's not good. That's sugar and butter and more sugar and butter and then a little chocolate at the end. So yeah, what I would say is you don't just have to eat green leaf vegetables, but there are other antioxidants that may help too.
Okay. We got many questions regarding occasional memory lapses and how concerned to be. Is it normal to forget the occasional word? Or I don't have a history of Alzheimer's, but I have trouble remembering regular words. If you find yourself able to remember names but not faces, or faces but not names, are those red flags?
Yep, great question. So as we age, our brains age too. Okay, and it is normal or expected that certain things change. And for example, oh, what was her name? We met on the set of some recording, and Lisa Gibbons was there, and we took this strange van to get to this TV shoot in New York City. Oh, her name, Paula. Her name was Paula. So I met Paula, over a decade ago, or 50, whatever the Facebook memory that popped up the other day said. I met Paula X number of years ago, but Paula's name was on the tip of my tongue. And I kept thinking and I kept thinking and I kept thinking and I remembered it later. So that is more associated with normal aging or age-related memory change or memory loss, where a word can be on the tip of your tongue, but you remember it later. And that is not something that is, I would say, definitive or entirely worrisome for Alzheimer's disease. It also, as we get older, while we may become more wise and more gray hair, which may be a good thing, sort of, I'll just say that. That's what I tell my therapist says it's a good thing. It makes me, be more distinguished. There we go. Um, when it comes to learning something new, it takes you longer to learn. So you may have wisdom, you may have intellectual knowledge and knowledge that will make you make better decisions as you get older. So that can actually get better, but it may take you longer to learn something, a new language, a new skill, learning a new language and learning a new musical instrument, taking adult education classes, attending, live Q&As like this, using the Retain Your Brain software. These are all things that can make your brain better, but it may take you longer to learn something or integrate it into the memory stores. So what I would say is that, those are things that I don't get too worried about. When someone has progressive short-term memory loss, they repeat the same story over and over. They forget dates, forget appointments. They're getting the sequencing wrong when they're trying to cook something, or they leave something on the stove, or they lose their keys and they can't find them. And I lose my cell phone, at least once a day, probably. I just like leave it somewhere and get distracted. The kids, the phone, whatever. I leave my coffee cup. Like I spent 10 minutes this morning. I couldn't find my coffee cup. I don't think that's like dementia or like early Alzheimer's. That's a distraction. Yeah, I left my coffee cup somewhere because my phone went off and I had to like do something, or the kids were screaming, or like something happened, or someone was at the door. I forgot to take out the garbage this morning. That's what it was. I had to run downstairs, took out the garbage. I came back up, no idea where my coffee was. That is not Alzheimer's disease. That is distraction. That is the other thing was aging, but progressive short-term memory loss, a change in personality, a change in sleep. These are things that I believe are a little bit more worrisome, and that really in now today in 2025 and onward in 2026 onward, soon to be, we need to talk to our doctors about that. Have an open and honest conversation. Have screening. Talk to your doctor. You can do some cognitive tests. There are some blood tests which have strengths and weaknesses, and we're doing a lot of research and work to try to democratize access to blood tests and really like educate the public about what a blood test really means and what the limitations are, and there could be false positives, and we don't want that. So yeah, talk to your doctor if you're worried about your memory.
What correlation have you seen between anxiety and brain health?
Hmm. So it's a tough question. I think my opinion on this has changed a little bit. As a person ages and as a person goes down the road towards Alzheimer's pathology, meaning the pathological proteins, amyloid, tau, and everything builds up, and the brain inflammation happens, and the brain cells, start to die and accelerate in terms of their aging. There are neuropsychiatric components of Alzheimer's disease, and depression, for example, is a risk factor for Alzheimer's. But I was always confused, like, oh, is it depression is a risk factor because they become less engaged, they don't socialize as much? It's like, different factors that are intertwined to increase the risk and accelerate cognitive decline and cognitive aging. Or is it that depression may be the earliest kind of psychiatric symptom of a dementia? And I didn't honestly know the difference, and I wasn't really clear. There's also a study that showed, it was the Holmes study, Dr. Holmes, Holmes, that showed that one of the drugs that treats dementia due to Alzheimer's, a drug called acetylcholinesterase inhibitor, donepezil, or Aricept. And these are only for people with symptoms that have been diagnosed with Alzheimer's dementia. When those drugs were used, it's an Alzheimer's drug for help memory, it also improved their anxiety and depression. So to me, I'm not sure about anxiety and dementia. I think anxiety could be an early or kind of related symptom due to dementia. But I also think that all anxiety on its own could be potentially a risk factor for dementia because when people are anxious, lots of things change. Usually anxiety and depression go hand in hand. Anxiety means you may not want to leave the house as much, you may want to sleep more, you may want to take a medicine called a benzodiazepine like a Valium or a Xanax or an Ativan to calm you down. Those things can probably add up to have like negative brain effects over time. Using those drugs for years and years, actually, I think is not the best idea. But sometimes you have to use them, and obviously talk to your doctor. But one thing I will say is that we always want to talk about non-drug approaches to treating mental health concerns, both depression and anxiety and sleep disorders, things like that, and talk to your doctor, psychiatrist, a therapist, etc. But what I would say is that there are drugs called SSRIs, selective serotonin reuptake inhibitors. And what I've seen, and based on the data, there's a specific set of SSRIs. In our clinical practice, we use it in very low doses and in very specific situations, not too frequently. But I've seen both in the data and in our practice that when you use low-dose SSRIs, escitalopram or Lexapro it's all generic now. And I have nothing to disclose, no relationships with any pharmaceutical companies, no relationships with any drug companies or vitamin companies, supplement companies. I don't do any of that. Try to just minimize my bias so people can listen to me and not be judged or thinking that I'm doing something or saying something for a specific reason. But when it comes to SSRIs, I believe that in the right person at the right dose for the right duration of time, said that a couple times, it may attenuate or slow down the accumulation of the amyloid protein. And I don't fully know why that is. I can tell you that I have a youngish guy, youngish, who had some brain proteins that were going in the wrong direction that I was a little worried about, or actually a lot worried about, because he's like a lot younger than 50, and we don't want people younger than 50 to start having brain proteins and some brain fog. That's too young. And he was actually started on an SSRI low dose, 5 milligrams escitalopram, and a couple of his brain marker proteins improved, and he improved symptomatically because he was having anxiety and he was having trouble flying and kind of just the world is closing in, and he was having a tough time, and he's doing a lot better now. So again, not advocating for the use of these drugs for the prevention of dementia or anything like that necessarily, but there could be some downstream effects. And again, talk to your doctor or a qualified healthcare professional.
Okay, thanks. This question comes from a persistent participant who's asked us multiple times. We have so many questions and we don't get to them all. So he asked again, he or she, if you take medicines for epilepsy, and he specifies topiramate, does that increase your risk for Alzheimer's? And then it says 30 years. I'm guessing the person has been taking the medication for 30 years, or they might be 30 years old. I'm not sure which. But.
Yeah. So, good question. I don't know that I have the best definitive evidence about anti-seizure medicines for increasing, decreasing, or having no risk of Alzheimer's. Topiramate or Topamax is a drug that I actually tried that once. I had headaches and I tried that once years ago, but I had some weird side effects. I couldn't taste soda. I couldn't taste the carbonation in soda, the bubbles. It's a carbonic anhydrase inhibitor, so soda tasted weird, which is probably good. I stopped drinking soda. It also kind of gave me some brain fog or some tip at the tongue. My words were a little funky. Anyway, so I know Topamax a lot because I did try it for about 6 weeks. And I'm not aware of any evidence that Topamax, topiramate, would have a negative effect on Alzheimer's risk, but it can kind of, I was taught in medical or residency or somewhere that they call it a Topamax is like Dopamax. It like dopes you up a little bit because it like kind of makes you makes you a little groggy. I don't think that's an Alzheimer's thing, but I don't know that I have definitive evidence. There are other drugs, like one of the drugs called valproic acid, Depakote, older drug, decades and decades old. That was often used for people who had psychiatric symptoms, for example, related to Alzheimer's. I think some of the data on topiramate or Depakote actually showed that maybe there was some not great effects. Can't remember it exactly. Maybe the brain atrophy increased or something. I don't think it's used very much anymore. But again, you can't like stop seizure medicine. Seizure medicines, like, are really important not to have seizures. And if you have a seizure while driving or like in the street, like bad things can happen. So, there are newer drugs like Keppra or levetiracetam, which is Lamictal, or Keppra, which is the brand name. But again, all these are generic now. I'm not really aware of an overall negative effect of the seizure drugs on brain health in the neurodegenerative category.
Okay, great. Thank you. What is the effect of cholesterol on Alzheimer's, and are there particular cholesterol particles or sizes that are especially associated or related to Alzheimer's?
Okay, we have an educated group today. I don't think I've ever been asked about different cholesterol particle sizes, so that's cool in a public. And I have from doctors for sure. Um, I've been looking at cholesterol particle size since 2007. I am possibly, probably one of the few, if any, back in 2007, neurologists that were ordering particle sizes on my patients. I was trained by Dr. Arthur Agatsson, who's one of the first preventive cardiologists on Earth. He developed the Agatsson calcium score, the calcium score that you may know of. He also is the author of the South Beach Diet. I met him before the South Beach Diet and before a lot of that stuff. But long story short, I basically want to say, let me start at the top first. Let me give you the general stuff. So total cholesterol is a number that I think a lot of people know. And some people say, oh, over 200, that could be bad, or less than 200, that's good. Like, actually, I don't look at total cholesterol. Total cholesterol is a number that's like a hodgepodge, and I'm not sure that, like, if total cholesterol is like over 250 or 300, then maybe something's going on, and that's a decent screen, like, to say, oh, we need to look more closely. But the next category down is LDL. Okay, low density lipoprotein, which is the bad cholesterol. HDL, high density HDL. People used to say it, or sorry, people still say it's good cholesterol, but that's complicated. I'm not sure I fully agree with that. There's a particle size answer to that, which we can get into. And then there's triglycerides. Triglycerides are those are bad. Like, that's easy. Higher triglycerides is just bad for metabolic syndrome. It's bad for brain. It's just not good. And that's kind of the basis that most people get. That is like really basic. We live in a sick care system, not a healthcare system. When someone has a problem, then our medical system pays for it. So getting these advanced particle tests usually is a preventive health test that insurance oftentimes doesn't pay for. So that's why most people haven't heard of it. But our sick care system, not our healthcare system, our sick care system pays for the HDL, LDL, triglycerides, and total cholesterol. When you go into the particle size, you can look at of the LDL particle, small and dense LDL particles. Sorry, this is a little complicated, but when you have really small and dense cholesterol things like little rocks, they go through the blood vessel wall and they hit the blood vessel wall, and they cause like an atheroma, redness, inflammation in the blood vessel wall. And the little rocks, they keep pinging and pinging and pinging. The small, dense LDL are bad, like really bad. But the big fluffy, the soft and fluffy, they're like beach balls. And the beach balls of cholesterol are like bouncing around in the blood vessels. Yeah, blood vessel walls are okay. They're just floating around, not causing damage, not causing blood vessel wall inflammation. So small, dense LDL is bad. We look for something called ApoB. ApoB. ApoB is important. And ApoB is a cholesterol particle that I think is even kind of the most important in terms of the cholesterol markers. And that's, a bad thing. And you could look at, for example, HDL particle size, HDL particle types. And you could do fractionated. Sorry, it's a big word, but different alpha subunit, beta subunit. This is complicated stuff, and I don't want to go too deep. And you know what? Maybe we need to do a whole, I don't know, video something on cholesterol in the brain and cholesterol and brain health for Retain Your Brain, and maybe we should do that. So I'll expand on this at some point. But there is another something I want to talk about cholesterol with LP little a. LP little a is an independent risk factor that is a cholesterol marker. ApoA1, ApoA1 is a type of HDL particle that is, the higher it is, the lower your risk of Alzheimer's, which is good, but only in ApoE4 positive people. This is a lot of like gobbledygook, and it's a lot of challenging stuff to summarize in a short period of time. But regarding different particle sizes, the answer to this question is yes, there is a difference, and not all people with high or borderline LDL are created equal. And not all cholesterol treatments are created equal, and not all people should be on the exact same cholesterol thing. And some people have high cholesterol but have no issues, no vascular inflammation, and no calcium buildup and clots and atherosclerosis, hardening of the arteries. And those people we don't have to treat as aggressively, or maybe some people we don't have to treat at all. So treat the patient, not the number. And just having a cholesterol number isn't sufficient in order for me as a clinician, as a physician, to make a treatment plan. I need to know much more comprehensively or holistically about that patient.
Regarding treatment, when statins are recommended as part of a treatment, there was multiple questions about
Mhm.
how do you know which is the right one for you? Is there a blood test that tells you what's the right one? Or do ApoE4 people have a certain one they take? Do you want to generally address statins and how the right one is chosen in the context of brain health?
Yeah. Is this being recorded? I guess I'm on the
Among
record.
family, remember?
Yeah, right. Oh, we're among family, sure. Okay, so there's a lot of stuff that people read on the internet about a lot of things, and things are complicated. And you know, I used to say this, and because we're among family, I'll say this, but this is a joke. This is a joke what I'm about to say. If I had to make a binary decision where I had to say only yes or only no, should statins be in the drinking water? And of course, I would never advocate for statins being in the drinking water. That's crazy. I wouldn't do that. But I'd say yes. What, Isaacson? What do you mean you can't put statins in drinking water? Statin medications, on the whole, for the majority of people, can really help people. I really believe that. Those are people that have vascular risk factors that are out of control, bad genetics, eat poorly, doing all the things the wrong way, overweight, metabolic syndrome, big belly, like blood sugar. Statins, uh, the totality of evidence suggests that statins are good. That's what I believe. However, okay, I do not just give statins to everyone. I actually uncommonly give statins. Well, how does that make sense? You just said they should be in the drink water. Well, no, because if you look at population health, an entire population, statins do more good than harm, in my opinion. But if you look at the individual sitting in front of me, I'm cautious with statins. I'm cautious with statins because there could be side effects, muscle cramping. There could also be side effects of over suppression of a specific cholesterol type, a sterol called desmosterol. Sorry, big words. And one day we'll hopefully be able to kind of share resources on how, people can, get access to some of these tests and in a way that, are quality tests that can be used for, to talk to your doctor about and to make, we create blood tests in our lab. Like that's what we do in our research. And, we're going to be, I hope in 2026, sooner than later, deploying a new research study through retainyourbrain.com software where we can be doing at-home testing. And this is a really, really, really exciting thing. And my group and our team has been working furiously, like literally around the clock on these tests. So one day I hope that some of these tests will be available. Again, research, not fully validated. We're trying to create the cholesterol test for the brain, as I colloquially call it. But there is a steroid called desmosterol, and most preventive cardiologists will know what this is, but otherwise it's hard to access. And statins can over suppress desmosterol. And in some people that may be bad, I'm not sure. And in people with the ApoE4 variant or two copies, I'm just a little bit more careful. The other thing I want to say about statins, again, I'm pro-statin, but I'm not pro-statin in the wrong person. There are other treatments. So there's statins, there's Zetia or ezetimibe. That's a generic name. Again, it's all generic. Ezetimibe is a plant sterol inhibitor. People can have high cholesterol for different reasons. They can overproduce cholesterol genetically. What do you do with that? Well, a statin can help that. People can overabsorb cholesterol genetically in the gut, in the stomach. That's a plant sterol inhibitor can go in the gut, and that way the cholesterol can't get in. Good. Okay. And then there's a drug that's injectable every other week called a PCSK9 inhibitor. That's a great drug. They're expensive, not covered by insurance the best. They should be. One day there should be a pill. It's been out for over a decade. If you haven't heard of it, you should, because it's really good. It can even help lead to reversal of the plaque in the heart. And for certain people that are higher risk, the PCSK9s are the things that we like. And one of them, like, again, no disclosures, no pharmaceutical relationships, is really safe for the brain. Like we have multiple years of data. So different people, depending on their genetics, need different cholesterol treatments. The problem is finding a doctor to do this is really hard. And one day I hope we'll, hopefully in 2026, we'll be able to deploy some, research grade stuff to help figure this stuff out. So I think precision medicine and personalized medicine and genomics, meaning checking a gene and figuring out like what drug you should be on. We're getting really close, and in our practice and our research program, we do that. Um, Oh yeah, yeah. And the other thing, let me just say one more thing: the dosing of statins. The dosing of statins kind of drives me a little crazy a little bit. I've seen people come in on such high doses of statins, and I'm like, I don't get it. And it's like that they started on a low dose and they went back and the doctor says it's still high. And every time they go back, like they just increase the dose. Like, okay, 85% of the cholesterol lowering effect of a statin, generally speaking, generalizing, is at the lowest dose.
Wow.
Crestor, rosuvastatin, high potency statin. I think I'm getting this right. 5 milligrams. You'll get 80% or whatever of the bang for the buck from just five. Then you go to 10, you get a little more. Then you go to 20 and you get a little more. And then you go to 40 and you get a little more. But the side effects go up like this, and the effectiveness on cholesterol lowering go up like this. And that's the challenge with cholesterol management for me. And I feel bad for doctors. Like doctors, like they get 15 minutes with a patient. Like they get like Medicare, like the reimbursements. It's crazy. I have a lot of empathy for doctors. So it's not, your doctor's fault. Trying to find a preventive medicine doctor or preventive cardiologist to help guide you, I think is the key. And I think, stay tuned in 2026, early 2026, I hope we'll hopefully roll out some research stuff that people can participate in.
Great. That's very exciting.
Mhm.
Um, I did the online survey and in Retain Your Brain, and I was curious why you didn't ask about recreational drugs like marijuana. And someone else also asked, what are the effects of marijuana on brain health?
Uh, Good question. So I don't know. Well, I know why we didn't ask it, but I don't know what the effects of marijuana are on brain health. And because I don't know, I think it hasn't really kind of injected itself into our quick screen. Now, thank you. I think I'm going to get this right. 86% of people that join Retain Your Brain complete all the surveys. It's something
Yep.
that's
Yeah. Almost
like
9 of 10.
to the
Yeah.
hundreds of people watching. That's awesome. Thank you. Thank you for completing all our surveys. And, we thought it was too long, but people are doing it, which is great. So we always have to be really careful about how many questions we can ask, and we try to ask the really core ones up front, and then we ask some more later. And Retain Your Brain is growing and growing and growing. And again, in a few months, you're going to have another version of Retain Your Brain roll out that I think people are going to really like a lot. I hope so. We didn't ask that question because I don't know what we would do with the answer. If someone is smoking a lot of marijuana, well, smoking isn't good because I don't like inhaled smoke, but tobacco I know is bad. That's like very bad, especially if you have one or more copies of the ApoE4 variant. Just like I know alcohol is bad, especially if you have one or more copies of the ApoE4 variant. But I don't really know with marijuana. I think smoking it is not as good. I mean, I think edibles are a different discussion. I don't, I think it's maybe better, but like, is it protective? I'm not really clear that it's protective either. And then there's like, well, what are you smoking? Like, is it like CBD version, THC? How much? Is it indica? Is it sativa? Where did they come from? Are there pesticides? I mean, there's just too many variables and a lack of standardization in research with marijuana in the brain that I'm confused. I've asked a professor that I worked with at Cornell, Professor Seth Rogen, who's the expert on this. I've asked him, and he's not sure. I think he's pro. Seth Rogen actually partnered with us several years ago for some educational coursework on Alzheimer's. This is actually true, and he wore my lab coat, and we taught, and we did this study about who's a better teacher, me or Seth Rogen, and Seth Rogen won, and I was really sad because I'm like a teacher and a professor at Cornell, and this guy Seth Rogen is beating me at lecturing. Great, but he thinks it's good. I don't know if you should trust Dr. Rogan, but for me, the jury is still out.
Right. Several questions about, is it important to be tested for ApoE? And someone else said, where can I get the test that will indicate how many copies of ApoE4 I have? My doctor didn't know about it. Another
Yep.
person said, my son was tested, and was his test sufficient for information for me? So just the basic understanding, kind of taking a
Yeah.
few steps back. You've mentioned it a few times.
Sure. So I really believe, and I'm passionate, that knowledge is power. I really believe that, and I also believe that if a person doesn't want to know their genetics and they're worried about it, then they shouldn't know their genetics. I've seen people paralyzed by fear, and fear is paralyzing. And when we, um, you know, are fearful, we're, paused into making action, into making a brain healthy choice and a change in our life that can, protect our brain health over time. So that's what I just want to start with. The next thing I want to say is genetic testing. I really feel passionate that is critical. Like I can't almost take care for a patient without knowing their ApoE4. And at the Alzheimer's Prevention Clinic in 6.5 years, two people decided not to take the test. And why? Well, they didn't want to, and I respect that, but 99% did. And why? Because I explained to them that having one or more copies of ApoE4 does not mean you're going to get Alzheimer's. And actually, not having any copies of ApoE4 doesn't mean you're not going to get Alzheimer's. To me, knowing your ApoE4 variant will allow us as a, partnership, that the doctor and the patient, to put a person on a plan to reduce their risk based on that genetic status. And the Retain Your Brain software, you can enter in your ApoE4 status and it will give you plans. Basically, we've written papers on this. Like someone anointed me the ApoE4 guy. Okay, I don't know how that happened, but that's what we do research on, right? So I think knowledge is power, and you can type it into the software. If you don't want to know, it's okay. Also, I think that having two copies of the ApoE4 variant, like the statistics out there that I see, 12% higher risk, 10% higher, 8% higher risk, or 8 times risk, 12-fold, 10 times risk, right? That's cuckoo. That's like population based. Hodge, put heterogeneous, put all these people together. Genes are not your destiny. You can win the tug of war against your genes. If a person with one or more copies of the ApoE4 variant follows a healthy lifestyle, exercises on a regular basis, doesn't have diabetes, high cholesterol, high blood pressure, has omega-3 fatty acids that are adequate, doesn't drink alcohol, doesn't smoke cigarettes, your risk of Alzheimer's is not 10 times, like it's just not. And we've shown this in our studies. And also doing a genetic test is just imprecise. In our new research, which hasn't been deployed yet, again, maybe 2026, I hope we're going to be doing this again through a research project through Retain Your Brain. It's all about the grant funding and the funding coming in, and it's a tough environment nowadays. But we hope that using a genetic test alone won't be what is happening in the future. We're going to use a genetic test and a protein test where you can measure the amount of ApoE4 protein in the blood. So you then take the ApoE4 genetic status and you take the protein expression, the amount that we can detect in the blood. We've done this over 650 people in our research study, that you can have E44 and actually express protein like an E34. You can be an ApoE34 and express protein as a, I don't know, closer to a 3.3. This is hot off the press stuff. We haven't published this stuff yet. So I think ApoE4 and genetic testing is the whole thing. I do want to say, because we're running out of time, how does anyone today, like right now, get their ApoE4 checked? Well, 23andMe. I have nothing to disclose in terms of any ongoing relationship or whatever. I did some videos for them in, I think, 2016, 2017. So if you go to 23andMe, you can, spit in a little thing. You do the health and ancestry version, the higher price one. Again, nothing. I take no kickbacks. I had no commercial relationship with 23andMe. You send back your spit, and then they tell you, and then a video of me pops up on their website, basically saying I have one or two copies of ApoE4. And then you can type that into the software. That is one way to do it. You can do it through genetic testing. Talk to your doctor. If your doctor doesn't know, that's one way. And there's other websites that do it too. But that's the way that most people have gotten it.
Several people in the live chat say they're concerned about 23andMe. The data is not private and they'll
Yeah.
sell your data. Is that a concern, do you think, that's worth keeping you?
Oh
Yes.
boy, I've struggled with this, and I've given the same answer even before the hack and after the hack, and I don't fully understand what happened, but I think there was a hack or something. Anyone that does 23andMe, I've always recommended, you know, using a separate email address, minimal, identifying information, not using your full name. I mean, there are ways to, protect yourself. I've been literally saying this, and you can opt out of research, you can opt out a lot. And then now with 23andMe, there's two-factor authentication. So you have to, just like Retain Your Brain requires a cell phone number, because the FDA, when we did all the research studies, said you have to, verify identity and whatever else. You can do two-factor authentication. All that being said, I can't vouch. I don't know. I don't know how 23andMe works behind the curtain. But if you can get your doctor to do it, and that's safer, that's great. The problem is, though, when you do it through your doctor, While there is the GINA Act, Genetic Information Non-Discrimination Act, when you do a genetic test, it goes in your medical chart. The insurance companies, medical insurance can't discriminate you and withhold insurance. Long-term care insurance um, may find that data and they may be less likely to insure you or increase your premium. So I think some of the reasons why people do genetic testing external to the medical system is because they don't want genetic results in the medical system. So I wish this was easier or better, but it's hard.
We're at the end of the time, but I wanted to ask, as we're going into the Thanksgiving holiday, one quick question: is red wine better than a cocktail?
Uh,
Did it
um,
taste better or better for your brain, I'm assuming?
Yeah, everything in moderation. I remember a couple of years ago, I was in Arizona. I was at the Dove Mountain Resort, one of the nicest places, at an event, an amazing event called Memories from Mary. This amazing guy Dave put on this fundraiser for us, and we had this exact discussion, and everyone was cheering with wine, and I'm drinking water. And everyone looking at me like, Isaacson, come on, you're the dud, whatever. And I'm like, no, actually, alcohol gives me headaches, but I would drink. I'd have a beer right now. I like Bud Light. I actually do like Bud Light. I like watered down beer. This is not a beer. This is iced tea. I promise. Watered down iced tea. Why wasn't I drinking? Because it gives me headaches. Everything in moderation. One glass of wine a couple times a week with a large meal, several hours before bed, like just isn't going to do that much negative to you. Granted, if people have two copies of the 8.4 variant or one, the more alcohol you have, the less well a brain does. So we'll say that. If you drink two glasses of wine right before bed, it's going to mess up your sleep-wake cycles. You're not going to have, adequate, good sleep, deep sleep, and REM sleep. And it's toxic. Like alcohol is a toxin. I mean, let's just be honest. It's a toxin. And the other thing about alcohol is, it's cumulative. So if you have alcohol occasionally, so everything in moderation, less is more. But I'm not really aware of definitive data to show that alcohol is good for the brain. I know there are some studies that show like low to moderate may be protective. I don't know. I think that's an individual decision. I think different people, if you have a liver problem, if you have high blood sugar, I think one has to be cautious about that stuff.
Great.
That's what I would say.
I wanted to remind everyone of two things real quick. One is that you can watch this full recording in a couple of days on the Learn page. When you open up Retain Your Brain, you can see this. You can see all the past sessions. If you've just joined recently, you can see ones before that. And the second thing is if you like getting tips and advice from Dr. Isaacson, he's running a holiday habit challenge over the next 6 weeks, starting next week, of just easy brain healthy habits that you can do that are around some of the stumbling blocks people have around the holidays. And you can also sign up for that. Just when you open it up, you'll see a pop-up inviting you to do that.
Love
So
it. And then one more thing. First of all, thank you so much, everyone, for being here. I really appreciate it. I cannot believe it, but the amount of people that started are like very similar. Same happened last time. There's like a dozen people that dropped off after an hour of talking of me blabbing and Paula being amazing. If everyone out there could take just 2 minutes of time, thank you so much for listening. Thank you for being here. Go to the chat. There is a survey. It's literally a short survey. We'll take 2 minutes. We read this, like we actually read this. I read this all the time. I read this. This is how we decide what to do with Retain Your Brain. We are a small mom and pop operation. We are grant funded. We are doing the best we can with limited funds, and we're really trying here. We will deploy our resources and our expertise to make new tools through Retain Your Brain for you. If you are interested in giving feedback about this Q&A, about what we should do, please share that feedback. We'd really, really, really appreciate it. And yes, there will be another session. We will get the recording. Another session is we haven't scheduled it yet. My fault. But we will schedule that in the coming week or so, and we will get that date out to you all shortly.